Hello, everybody. My name is Dr. Osman Ali. It's nice to present a case that may meet in the NAC exam. It's a jaundice. So today is how to approach the case of a jaundice. This presentation is arranged by the medical education programs. Let's go. This is one of the clinical scenario, and the doorway information state that's a case of 50 years old guy who presents because of worsening abdominal pain and yellow skin for the past 2 weeks. The vital signs mentioned here, and the examination our examining tasks is to obtain a detailed medical history and perform a relevant physical exam and discuss your initial diagnosis, impression, and your work plan with the patient. In this diagram, it shows that jaundice is classified into unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia. Usually, the unconjugated hyperbilirubinemia is prehepatic, and the conjugated hyperbilirubinemia usually comes hepatic or post-hepatic. So we will start here to evaluate the case as a whole by taking the history of present illnesses and also past medical history. Then we will do physical exam and request some investigations to reach diagnosis and discuss this with the patient. While we are taking the history of present illnesses, we have to start to ask about the onset, when the disease started, the durations for how long, and the other associated symptoms like the color of the stool and urine. Usually, if there is a jaundice, we can find this in deep color of urine or dark in urine, or stool. It looks like pale. Other prodromal symptoms like fever, malaise, or myalgia before the jaundice. If there is itching, pruritus, if there is steatorrhea, this is a greasy stool or the floating stool in the toilet. We don't forget ask to signs or symptoms of the malignancy like weight loss, for how weight and before and after. Then lastly, we ask about the pain. This is mentioned in the scenario, so we have to start asking about the location, the severity of pain using the pain scale, and also duration, and if this pain is localized or radiates somewhere. One of the main components of checking history is a past medical history. Past medical history, we start checking or asking about the surgical history, previous surgeries on the biliary tract, it could be a potential cause of strictures. And then we go to the social history. We ask for risk factors of hepatitis, history of travel, amount and the duration of alcohol use if this patient's using alcohol, or we asking also about recent use of any medications like painkiller, NSAIDs, paracetamol. And then we ask about the sexual history, recent sexual history, and over 6 weeks or even 8 weeks. This is a source of infections. Family history, we can go to ask about the related inherited diseases that may cause jaundice, like for example anemia, certain kinds of anemia, certain kinds of hemolysis, certain kinds of syndromes, as we mentioned before. Yeah, we reach here to the physical examination. Keep in your minds the vital signs that were given at the doorway information, and you have to keep in mind that if there is signs of toxicity, if there's a fevers, hypertension, tachycardia, and then you check the general appearance. General appearance is noted as if it's the patient cachectic or lethargic, And then check head and neck examination also include inspection of sclera for icterus, and the under the tongue, the mucous membrane under the tongue, and the yellowish skin usually appears in the jaundice if the bilirubin levels greater than 3.5 mg per deciliter. And then we go to the abdomen. It's the most important, of course, to be examined because it's very relevant to the case. We inspect it for collateral vasculatures like caput medusa, also spider nevi, if there is ascites, projections of the flanks at the foot of the bed, and also the surgical, if there's a surgical scars. So we have to comment all over the abdomen, everything we found in the abdomen we have to comment on by inspection, and then we'll go to palpation. What we will find in the palpations, we have to examine the liver and spleen. It's very important organs in this such case of the jaundice. During palpation of the abdomen, we examined the for evidence of ascites by doing the shifting dullness and fluid thrill test. By palpation also we go to find any masses or detect any tenderness. For the liver, we have to define also if it's enlarged or not, any masses, any nodularity, any tenderness, and the liver span we have to mention. The other organ is spleen. Evidence of splenomegaly is very important clue in diagnosis of liver disease itself. Not only liver disease may be due to blood disorders, but should be palpated and should be defined the size and if there's splenomegaly or not. The other test in the men, we examine also for finding any testicular atrophy or gynecomastia. But here in this scenario, or the Doran formation, he said, don't examine genitalia, so we have to comply with this task, and we will not go to examine the genitalia. Yeah, in this diagram, it shows how to start examine or palpate the spleen. As we mentioned, we can start from the right iliac fossa, and then we cross to the abdomen toward the left upper quadrant region. The above diagram, it shows how to detect spleen enlargement by percussion of the Trops area. Trops area landmarks, it's very clear here. It's started by mid-axillary line, and the from the void process and the costal margin, we cross the line, the midpoint between a line from mid-axillary line and the line from the void process to the costal margin. And in this area, we have to percuss. If this area is dull, it means huge splenomegaly, because normally the Trops area is resonant. We will start request, for example, the CBC, and CBC it may shows reduced platelets counts and anemia that are common in cirrhotic patients. CBC can show for us also the leukocytosis if it's there. It's a marked elevation may suggest cholangitis or cholecystitis. The other test we request is a liver function test, and liver function test may show us or unreveal the pattern entry of the liver. For example, we will go to ALT and AST. Normal alkaline phosphatase and aminotransferases here, if they are normal, it indicates that there is a hemolysis or inherited disorders of bilirubin metabolism that may be responsible for hyperbilirubinemia. If the alkaline phosphatase elevation is so high, usually it suggests biliary obstructions or intrahepatic cholestasis. If there is high elevations of ALT or AST, This is high elevation of aminotransferase. It suggests usually hepatocellular, intrinsic hepatocellular, usually viral hepatitis. If the ratio of AST to ALT can point towards the etiology of the liver disease as well, usually alcoholic cirrhosis. AST to ALT ratio, if it's high, it means alcoholic cirrhosis. We also request for pancreatic dysfunctions, amylase and lipase. This can cause or refer to any pancreatic involvement. The others we can request like PT-INR. This is for the liver functions intact or not, and this is also shows us how to liver works. If we go to advanced test, we suspect that, especially in the elderly patient, we can go to the tumor markers or pancreas, for example, CA19-9, or alpha-fetoprotein is a marker also for hepatocellular carcinoma. But usually we start by simple tests as CBC, liver function test, and will not proceed to further investigation until we find a good indication for that. After the initial investigations we requested, we proceed to further investigation such as serologic tests for viral hepatitis, measurement of anti-mitochondrial antibodies for primary biliary cirrhosis. We measure also the anti-nuclear and smooth muscles, liver kidney microsomal antibodies for autoimmune hepatitis. We check serum levels of iron, transferrin, ferritin for hemochromatosis, metabolic disorders, and we check also the urinary and serum cover for Wilson disease. Serum levels of ceruloplasmin involved also in the Wilson disease. After that, we go to the radiological imaging or imaging tests. We request first the abdominal ultrasound. Abdominal ultrasound is the least expensive and least invasive technique. Should be the first test done for those with jaundice. It visualizes the bile ducts, ecotextures of the liver, gallbladder, and pancreas. Normal common bile duct diameters, it's shown for millimeters. When ultrasound is performed with Doppler, direction of the portal blood flow and the presence of the thrombi in the portal system can be determined. Next is CT scan. It's more accurate in pancreatic lesion. If the results are positive for extrahepatic cholestasis, the tests may be necessary to determine the cause by using MRCP and ERCP. Finally, or lastly, we can need to perform a liver biopsy. It's not commonly required, but can help in diagnosis autoimmune hepatitis or biliary tract disorders, especially primary biliary cirrhosis and primary sclerosing cholangitis. To conclude, or an overview, we can summarize our workups as the following. Acute jaundice, particularly with viral prodrome in the young and healthy, suggest acute viral hepatitis. Painless jaundice in elderly patient with weight loss and abdominal mass and minimal pruritus suggest biliary obstructions caused by cancer. Predominant increase in aminotransferase suggests hepatocellular dysfunction. Predominant increase in alkaline phosphatase suggests cholestasis. We can also mention that the patient who is in this clinical scenario, who has abdominal pain and jaundice, these patients may have cholestasis, may have gallbladder disease, or may have pain or hepatocellular injury due to drug toxicity. This is an example for some blood test that may given by the examiner to comment on or interpret, or to give the impression about the diagnosis for this case of jaundice. After finishing the talk with the patients, we have to thank the patients for this examination, and we have also to ask the patients if he has any questions or concerns. We have to listen to him and to answer these questions before leaving the room, and then waiting the examiner if he start to ask you questions or to ask you to answer any concern also for the examiner. And we thank all also for the listeners and our colleagues. I hope that I covered this topic because it's very important and maybe frequently topic in the NAC exam. Thank you so much.